Today we are starting a series of lectures on mastering basic and clinical cardiology, right? In this series of lectures, we will be discussing all the foundations of the cardiovascular system, all its physiology, anatomy, pathology, pharmacology, and at the top, clinical cardiology in detail, including the all ECG related stuff. So let's start with the very beginning, that we will be starting with the SA node, sinoatrial node. Now when we talk about the sinoatrial node, everyone knows that sinoatrial node is basically a structure in the heart and which is the dominant pacemaker of the heart, right? Which is spontaneously producing action potentials. Now sinoatrial node has a capacity of automaticity. What we mean by automaticity is that a tissue has tendency to produce spontaneous depolarizations, right? Or we can say tissue can automatically produce action potentials, or tissue can automatically produce electrical impulses. So when we say that what is SA node? We say SA node is a region in the heart. I will go into detail where is this region, which has a very specialized function. It consists of basically specialized myocardial cells or modified myocardial cells which have specialized in producing spontaneous depolarizations almost every 0.8 second, right? And they basically control the rhythm of the heart or pulse rate in physiological circumstances or healthy person. SA node is so master in producing automatic impulses that every day in a healthy person, SA node can produce more than 100,000 impulses. And in a roughly normal lifespan of a person, SA node produces automatically depolarizations more than 3 billion times, not 3 million, 3 billions, right? So as far as we can say SA nodal activity is concerned, you are all billionaire, right? That billions of times, if you have normal lifespan 70 to 80 years or 90 years depending upon so many factors, then it is such a powerful, tiny but powerful tissue that it in your lifetime it can produce depolarization how many times? 3 billion times. Now when we study SA node or sinoatrial node, number one, we have to study about the concepts related with its anatomy and structure. And number two, we have to study its physiological aspect, that what are its electrophysiological properties. So this lecture is concerned about anatomical and structural concepts related with the SA node, right? Now, my very first question is that what is the exact and precise location of SA node in your heart? Now, yes, you must be looking this mermaid, beautiful mermaid. Later on, I will tell you this is actually our SA node living in our heart. We'll talk about that later. But first of all, if we just ask a random doctor, average medical person, where is SA node exactly located? Usually the answer is that it is located in right atrium. It is located in, this is right atrium, this is right ventricle, this is pulmonary artery, this is superior vena cava and inferior vena cava. They say this is located in right atrium. But where in the right atrium? Then someone good will tell you that it is present in upper right atrium, right? Upper right atrium. But I want you to be more precise. If we add one more layer to this, it is not only in the right atrium, not only in the upper and posterior part of the right atrium. Let me tell you that if I show right atrium like that, This is a very simple diagram. Let's suppose this is right atrial outer wall, this is septum, there is left atrium there. That's a very simple diagram. Now, SA node number 1, we used to show it that if this is the right atrium, right, it is in upper part and posterior part and lateral part. Now look here, this is lateral, this is upper, and that is posterior. So usually, classically, it was drawn like this, that SA nodal tissue is present in right atrium, its upper, posterior and lateral corner, right? Now, this concept is not right. At least, if someone insists this concept is right, this is old concept, classical explanation in cardiology, that SA node, that students think that SA node is some sort of tissue like a button or pinhead which is present in the right atrium upper part, but this is not totally accurate, right? Now cardiology has advanced a lot and we need to know SA node very well, because damage to SA node during different procedures and interventions can produce a lot of rhythm problems. So a good doctor knows exactly where is the SA node, right? So what we'll say, that this is in the atria, in upper atrium, posterolateral area. But if you want to be more precise, you will say that SA node is present at the upper cavo-atrial junction. This is superior vena cava, this is right atrium, right? At this junction, it is present. So I'll put it over here initially. So what is this? This is, yes, cavo-atrial junction, right? Now, in right atrium, with the superior cavo-atrial junction, because there is inferior cavo-atrial junction here also, but superior cavo-atrial junction, we used to think that it is there. But now modern concept is more elaborated. Now we believe that SA node is present, of course, at the junction of superior vena cava and right atrium outer wall, but this is not something rounded or oval. It is elongated and spindle, right? It is something like, I must say, like this. We can say that it is present over here and it is going down like this. This is its head. There is a body of SA node and there is tail. So it is elongated spindle shaped structure, not oval or button. Secondly, the way we used to show it previously, that if this is right atrium, we used to show that it is here. Apparently, it looks as if it has very well-defined border. But SA nodal tissue does not have any discrete visible boundaries. SA nodal tissue does not have any discrete visible boundaries. So to know its exact position, we need to know the special anatomical landmarks around it. To know its exact location, we should be aware of what are the anatomical landmarks which are around the SA nodal tissue. And now, let's come over here that we assume that SA node is present over here, right? What is this point? It is upper posterior lateral part of the right atrium where it is meeting with the superior vena cava, right? So first point which you have to remember, that is, okay, I will write it the points here. The very first point to know its precise position, it is cavo-atrial, superior cavo-atrial junction, superior cavo-atrial junction, number one. Number two, it is not something circular or something oval. It is actually modified myocardial cells collection with some connective tissue, which does not have any discrete borders, which does not have any clear-cut borders, and with naked eye you cannot identify its margins. If you really want to identify its margin, maybe you can do it histological studies, right? But because this structure is not visible to the naked eye, and in modern cardiology there are so many procedures we do here, right? We do superior vena cava cannulation, we do catheter ablation in this area, we do cardiac surgery in this area, but we have to be very careful that we should not damage SA nodal tissue, right? I will prefer that we should not call it SA node, because it is not a very well circumscribed node. It is actually a region where the modified myocardial cells have developed the capacity of automaticity, right? So SA nodal region, exactly where it is, the first thing I told you, superior cavo-atrial junction. But that is not enough to know. There are other landmarks also. Let's suppose this wall I draw here. Now I am going to draw this component in which SA nodal tissue is present, and I am going to draw it here on this board. This is outer side of the atrial wall, right atrial wall. This is intracardiac or internal side, right? Now, here I draw the outer side. Here I draw the outer side, and here I draw the inner side. Now, this is your SA node. So, what we have done, I have expanded like this and like that. Now, here is our SA node. By this shape, I want you to remind that it is not a button, this is not a pinhead, it is an elongated structure, and of course it's not a truly mermaid, but it is an elongated structure having a head and a body and a tail, right? Its head is, yes, at superior cavo-atrial junction within the outer wall of right atrium. And you can see that, let's suppose if I draw atrium like this, okay, I will make it more simple. Let's suppose I draw atrium like that. This is suppose right atrium, right? It's a very simple diagram. And if I show, here is superior vena cava coming, and this is superior vena cava and meeting its atrial wall, right? Okay, we can make it more simple rather. And here it should be which entrance? Inferior vena cava. And this is your atrium. Okay, with the inferior vena cava. We will bring this doll also into our discussion. This is inferior vena cava. Now, you know in right atrium superior vena cava drains, inferior vena cava drain, and good doctors know that at this area another drainage is coming, which is coronary sinus. We'll discuss that later. up to now, this beautiful mermaid, or I will call it nodal region, right? This, I'm going to put it here, right? This is its head, this is its body, and this is its tail. Now, first point was superior atriocaval junction. This is above it. Now, what is outside it? Outside it, there is pericardium. How the pericardium is here? If I draw a little heart here, suppose a very simple diagram of heart. This is pericardium over here, pericardial sac. You know, this layer of pericardium, this is called visceral pericardium. This is parietal pericardium. Now, this visceral pericardium is touching here. Yes, where? Right atrial outer wall. Now, this area is also called epicardium. This visceral layer is also called epicardium. Now, if we come to this diagram, so epicardium is over here, right? And if epicardium is over here, then we will say the head of mermaid or head of node is under the epicardium. It is inside, just little deep to the pericardium, epicardium. So we can also call it that its head is located subepicardially. Their head is subepicardial position. Subepicardial position. Now we have seen two positions. Position number one is that I was telling that what was here? Head. Right? And head was at which position? Superior cavo-atrial junction. Then, and present it is upper limit, and this is one of the most constant location. Then, if you look from outside, there is a very little myocardium here. There is a very little myocardium here, about just 1 millimeter thick. But here, myocardium is quite thick. Now, what we see? That it is more situated, more near the epicardium and away from the endocardium, because inner lining is endocardium. So we cannot say, if someone says that it is subendocardially, it is wrong. Nodal region is subepicardially, right? And from here, from this subepicardial position and from the just below the superior cavo-atrial junction, this tissue is spreading downward and elongated, and it goes a little inward within the wall. It means basically it is intramural. Intramural means that within the wall of atrium, but it is more near the epicardium and less near the endocardium. Is that right? Number one. Now, we have seen its upper limit, we have seen its outer side, right? What about its lower limit? Actually, its lower limit is very variable. Upper limit is relatively fixed. That depends on the length of this tissue, acinodal tissue. It can be 1 to 2 centimeter long. In some people it is just 10 millimeter or 1 centimeter long. In some people it can go up to 20 millimeter or 2 centimeter long, and even in some normal heart you may find it is a little more longer. So it means its length is variable, right? So length is about how much? Let's suppose this is present over here. So its length, it is looking epicardium. If we think this is, now this is our acinode, here's the head, here's the body, and here is lower endotail. Now this is epicardium with very little myocardium in between. Here is endocardium with lot of myocardium in between, right? So here epicardium with very little myocardium, and on inner side endocardium but significant distance due to presence of myocardium. So it, even though this specialized myocardial tissue or acinodal region, right, it is intramural, but it is not in the center. It is not to the endocardium, it is to the epicardium. So just above it, what is coming? Superior vena cava. What is just outside? She is looking to epicardial side, right? Her back is towards endocardial side. Is that clear? Her length is 1 centimeter to 2 centimeters or sometimes 2.5 centimeter. And its width is 2 to 3 millimeters, right? And thickness is just 1 to 2 millimeter. It means it is not a node. It is not something like a sphere. It is not something like oval nodule. It is just like a mermaid. It is just like a mermaid in your heart. It's just like a little doll in your heart. Where this doll is present? In the right atrium. Where? Right atrial, outer wall, upper corner, posterior corner, where superior vena cava junction is present with the atrium, right? And there it has its head, which is more near the epicardial side, so we call it subepicardial position, and then it is elongated and its length may be 10 millimeter to 20 millimeters, sometimes up to 25 millimeters. Its width is about how much? 2 to 3 millimeters, sometimes 5 millimeter, and its thickness is just 1 to 2 millimeter, right? This is one thing. Now from these dimensions, you must have learned that its size is not fixed. Size is variable, right? And this has a lot of clinical importance. When we are doing certain procedures in this area, we need to protect the acinodal region. Now, so what are the anatomical landmarks other than what I have already discussed, right? I'm going to make a structure here. Superior vena cava, very important landmark, right? Right atrial outer wall, right? This is right atrial septum, right? Now, here it is right atrial posterior side. So if you are inside the right atrium, okay, you are standing over here. if you look up, this is upper corner, upper posterior corner, where what is coming? Superior vena cava, right? Now, there is one thing very important here. If you look outside from within, here there is a rough ridge elevation, internal side. If I draw this wall here, that if this is the wall, and we have made a section, here was your acinodal head. Actually, atrial wall will have a sulcus here, a longitudinal depression, and this depression will be going from superior vena cava to inferior vena cava. How you can visualize that? Let's come to this diagram here. This is from the posterior aspect of the heart. This is posterolateral aspect of the right atrium. This is superior vena cava. Here is inferior vena cava. We are looking from the back. Now you see, there is a yellow groove here. From external aspect, you can see that right atrium, from posterolateral aspect, if you look, right atrium has a sulcus or groove which is called sulcus terminalis. It extends from superior vena cava up to the inferior vena cava. This is a very important anatomical landmark. Now, what is the importance of this landmark? Let me tell you. This sulcus, here is our acinode, right? Now, this is endocardial side, this is subepicardial side. Outside, there is a depression. Outside, there is a depression. This is the longitudinal depression under which this is present. Now, we can say that when it is looking outside, it is looking through just very thin curtain of atrial myocardium, 1 centimeter, 1 millimeter, and outside there is a sulcus, and this longitudinal sulcus which is coming down, it is limited into upper part of sulcus, right? The sulcus is full of, you can say, fat pad. It is going throughout. So we can say that this area, this sulcus, if I show it here, right? This is full of what? Fat pad. Fatty material is here. Now, this is longitudinal depression. This is called terminal sulcus. When we take this doll, right, it is looking outward. What it will find? First of all, a very thin layer of 1 millimeter atrial myocardium. Behind it is a very thick atrial myocardium, and then endocardium. Here it is a sulcus. And sulcus is full of what? There is outside there is a sulcus, and sulcus is full of fat pad. And over that fat there is pericardial layer, visceral pericardial layer. So we say it, even though it is within the wall, but it is subpericardial, but between the acinodal tissue there is a very thin layer of atrial myocardium, and then there is fat pad which is filling the terminal sulcus, and which is also called sulcus terminalis, and then subpericardial position. So now we can say we have done how many landmarks? We have done 3 landmarks, right? One landmark above it, yes, superior cavo-atrial junction. Second landmark, I said outside, it was subpericardial, but subepicardial, and between the epicardium and the atrial wall has a longitudinal depression which is extending from superior vena cava, atrial wall, longitudinal depression as a sulcus continues up to inferior vena cava, and that is full of pad, fat pad, right? So looking outside, thin layer of atrium, 1 millimeter, atrial wall or atrial myocardium very thin, then sulcus terminalis having fat pad, and then visceral pericardium. And if you go beyond it, what will be this? Parietal pericardium. And outside the parietal pericardium, here is something extremely important and longitudinal going on, and this is the nerve, and this nerve is phrenic nerve going to diaphragm, right phrenic nerve. Why these things are important? Because when you are dealing in this area, right, actually you can injure the phrenic nerve, you can injure the structures present in this fat, you can injure the head of this superior most part of the acinodal tissue, right? Now, these are the structures or landmarks related with upper and outer part. Now, landmarks inward, right? If we talk about the inward landmarks, actually, here there is, from here up to here, what is this? Yes, atrial myocardium. This is all wall of atrial myocardium. She is embedded in that. This is wall of the atrium, outer wall. Actually, here was the long sulcus. Just opposite to sulcus, inside, there is a muscular, very thick ridge or elevation going downward. For example, these are atrial muscles, and this ridge is going like this. You can say it's a mountain range. It is like a mountain range. So it means our mermaid is below the superior vena cava, right? Just inside the sulcus terminalis, subpericardially, and just subepicardially, and deeper to, but very deep to, what is this structure? Crista terminalis. What is it called? Crista terminalis. Now we can see it here. This is our beautiful mermaid, right? There's the head. What is coming here? Superior vena cava. First, very thin layer of atrial myocardium. After that, there is sulcus, like sulcus, right? After that, sulcus is full of fat pad longitudinally. Then visceral pericardium. Then parietal pericardium. And then very important anatomical structure, phrenic nerve, right? But if you look inward, then as compared to outward, inward, it is covered by relatively big area of atrial myocardium. And then there is a ridge, very longitudinally, there is a ridge of muscles, right? This is called crista terminalis. So we can say our doll or our mermaid is having two anatomically very important area with which it is related, but it is not present in those anatomical area. Outer side, sulcus terminalis. Sulcus terminalis is a pointer towards the acinodal tissue, but acinodal tissue is not present in the sulcus terminalis. In the same way, when you go inside the heart, there is crista terminalis. Crista terminalis, if you are having catheter endoscopy, if you look at the crista terminalis, this is a pointer that deep inside there is acinodal tissue. But acinodal tissue is not inside the crista terminalis. These are just anatomical landmarks. Now I want to make it more crystal clear. Now you will tell me that how it is arranged. Now, what is this location? Superior cavo-atrial, and it is related to upper limit of acinode, which is more near to epicardium and less near to endocardium. It is widest in upper part, elongated lower. Here there is a, what is this? Upper part of sulcus terminalis, because it is going up to inferior vena cava. But acinodal tissue does not extend to the inferior vena cava. And inside, what is this here? Crista terminalis. This also extends from superior vena cava to inferior vena cava. So, if you are inside the atrium, you are looking at the crista terminalis, which is a vertical groove made of muscles, atrial muscles, and if you are outside, you are looking at the sulcus, groove-like depression in the outer aspect of atria, extending from superior vena cava region to inferior vena cava. In between them, in their upper part of the sulcus, this is upper part of the sulcus, and this is the upper part of crista, right? Here is your acinodal tissue. Now, how many landmarks? 3 landmarks. First landmark is, first of all, it is in the right atrium. Acinodal tissue is in the right atrium, in its upper, posterior and lateral wall. Exactly, it starts from superior, what is this? Cavo-atrial junction. It is subepicardially present, but anatomical landmark just outside it is sulcus terminalis, then fatty tissue, and then visceral pericardium, then parietal pericardium, then phrenic nerve, right? This is upper part of it. And what is this? Crista terminalis, and upper part of it, even though crista terminalis. So now, and below it, there is regular atrial myocardium. It depends on how elongated it is, what is the length of it. So, I would like that I make a jar like this, put my doll here, here superior cavo-atrial junction. Here sulcus terminalis. Here crista terminalis. Now these situations we have seen. We'll go beyond that also. Now this is our beautiful doll here. Now you are going to tell me, what is this coming? What is this junction? Superior cavo-atrial junction. What is this first layer of very thin layer of myocardium? Atrial myocardium, just 1 millimeter. After that, just outside that, there is a sulcus. What is the name of that sulcus? Sulcus terminalis, which extends from superior vena cava to inferior vena cava. It is full of what? Fat pad. Fat pad. Then that is covered by visceral pericardium. Then that is covered by parietal pericardium. Then outside, one important structure is very important, that is phrenic nerve. There are other structures also, but why I'm talking about phrenic nerve, because sometimes when we are doing interventions from outer aspect to cavo-atrial junction, we might damage the phrenic nerve, right? Now, we come inside. Inside, here, there's a lot of atrial myocardium, regular myocardium. But here is elongated ridge of muscle. What is this? Crista terminalis. So from inside, it is deep to the crista terminalis, but not within the crista terminalis. From outside, it is just deep to sulcus terminalis, but not inside the sulcus terminalis. Above, it is at the junction of superior cavo-atrial junction, but not inside that junction, or it might go a little up. Now these are just anatomical landmarks. Why these are so important to recognize? Because if you are doing surgery or any other interventions or catheter ablations, you have to prevent the whole system of SA node, because it is responsible to produce not millions, billions of time rhythm, and if you damage this, cardiac rhythm will be messed up, right? Now we know what is above, what is just inside, what is outside. But we have to see one thing, that we have seen inside, we have seen inside, outside, we have seen above, we have seen below. What is coming in front and what is going back? It means if there is crista terminalis here, there is something going from back, the posterior wall, posteromedial wall of atrium, atrial cavity, posteromedial wall of atrial cavity coming here. And what is this? Anterolateral wall of atrial cavity. Is that right? Now, again I will repeat it, that if this is our doll, right, here, what is going on? This is anterior side, this is posterior side, this is outer side of the heart, atrium, this is the inner side of the right atrial wall. So this is in the right atrial wall, right, upper part. Now, we have already discussed that cavo-atrial superior junction, sulcus terminalis, subepicardially, epicardially, then here was crista terminalis. I'm talking about that this is present in this corner, upper corner, posterior corner, lateral corner. But from here, atrial wall is moving forward, laterally, and then anteriorly. And here it is coming interior. It is my heart. If it is my heart, let's suppose this is my doll, not yours. I'm a little possessive. Now, if it is my doll, and this is my right atrium, this wall is going interior, and this wall is going posterior, and here will be septum. You are understanding? Here will be septum. So, what is this wall? Anterolateral wall of atrium and atrial cavity, and this is posteromedial wall, because this is medial and here it is posterior, right? And here it is true medial septum. You are getting it? Posteromedial and then septum, then interior. It's a ball. It's like a ball. Yes.
When we are moving from this point.
Let me tell you. Let me explain it. In a diagram, suppose this is your atrium, right? Here is coming your superior vena cava, opening here. And what is opening here? Inferior vena cava. And what is here? There is a valve here. What is this valve? Tricuspid valve. And there was opening of sinus opening. Right? Now, actually, this is posteromedial side. This is anterolateral side. This is anterior and lateral. This is posterior and medial. Now, where is our doll? Our doll is present in this area. Right? Then sulcus is here going longitudinally downward. And the muscular ridge was here. You get it? And this is also going elongated downward. If this picture is clear, now we come to our doll, which we put it here. Okay. This is doll. Just for orientation. This is superior part. This, first of all, this doll is present within the right atrial outer wall. And the outer wall, it is not in the middle, it is not to the inner side. This is as much towards the outer side of the outer wall as possible. Right? So we call it subepicardial position of this tissue. This doll is actually acynodal tissue or acynodal region which has specialized in producing what? Producing automatic impulses and creating rhythm for the heart, which is called sinus rhythm. Right. Now, upper you already know. You will tell me these things, then I will teach ahead. What was this coming? Superior vena cava. What is the sulcus outside? Sulcus terminalis. What was the vertical ridge here? Crista terminalis. Right? And both sulcus is also going down. Crista terminalis is also going down. It is in upper part of these, in between these two things. But it is not the part of sulcus. It is under the sulcus inside. It is not part of crista. It is not inside the crista, but it is deeper to the crista. Is that right? These are, and now actually, when cardiology was not well developed, cardiac interventions were not so common, right? These things were not so important, but now they have become extremely important. You cannot practice modern cardiology if you don't understand these relationships. Now, once you have understood this, three landmarks, upper landmark, outer landmarks, and inner landmarks. Now, interior. This is anterior anterolateral wall. This is posteromedial wall. Is that clear? Now, if you look at the posteromedial wall, that is very smooth. If you are standing inside the cavity and look at the back, the posteromedial wall of the right atrium is very smooth. Its lining is just like a big vein. Right? Look here. Superior vena cava, inferior vena cava, and this blue area, we have opened the interior wall. We have opened some part to this side, we have put a cut, some part to that side, and some part upward. And now we are looking at what? Posterior wall. Right? Now, this is fossa ovalis, we will not discuss it now. Posterior wall, this is very smooth. It's as smooth as the wall of a big vein. Right? So, Crista terminalis is a special border. This is mountain range. Behind this, there is just plains. They are just plains, smooth area. And from Crista terminalis, if you move forward, you move anterolaterally. this is very rough area. I told you the mountain ranges starting here. Why? Why it is smooth? Why it is rough? Answer is due in embryology. During the development of the heart, if you know basic development of the heart, the smooth part, right part of the sinus venosus is incorporated in the right atrium as its posterior wall. I will repeat it. Right portion of sinus venosus, which is very plain wall, is incorporated during the embryological development. Incorporated, it becomes the part of posterior wall of right atrium. And this part of sinus venosus, as it is making the posterior wall like this blue, and it moves laterally and little interiorly, it will have like mountain range. What is this? Crista terminalis. It is made of what? Muscles, atrial muscles. And then you move forward, you are with the lateral wall and then anterior wall. You will find that this lateral wall here and interior wall here, they are very rough. They are uneven. We call them trabeculated part of right atrium. Right? And this pocket, look here, it's moving forward, outward, forward, and then turns actually interiorly and going towards the inner side of the heart. This curve, this is also called atrial appendage. This is also called atrial appendage. Now, we can say interior to the, what is this? Acinodal tissue, there is atrial appendage wall. And this is trabeculated wall. This is uneven wall. Right? Now, why it is trabeculated? Why it is uneven? Actually, embryologically, it is derived from primitive atrium. Again, just for a integration. What was here? Crista terminalis. Crista terminalis, if you go back, smooth part of the atrial wall, what is it? This is derived from incorporation of right part of sinus venosus. But this part, which is derived from the sinus venosus, this is called sinus venerum. What is it called? Sinus venerum. So, now this is my acinodal tissue, right? What is this wall? Sinus venerum. From where it is derived? Right side of the sinus venosus. Which wall of right atrium it is? Posterior wall. Okay, we make it more clear. Posterior wall. So, if from this mountain ranges, if you go backward, you find plains. You find plains. But if you move forward from this mountain ranges, right, this is as plain as you can see this, right, very plain, this area. Don't laugh, there's a problem. Some students told me when they laugh at my head, shining head, their hair fall start, right? So be careful. Okay, let's move. So this was, what is this? Posterior wall of right atrium. Smooth part of posterior wall of right atrium. Also called sinus venerum. And it is derived from right part of sinus venosus. Clear? Then there is a muscular mountains, ridge, long mountain ranges there. From this mountain range, muscles are moving forward into lateral and anterior part of right atrial cavity. The muscles which are extending like this, they are just like my fingers. It is just like that mountain range is like a comb, and these are the extensions from the combs. Or we can say there's mountain range, and from there mountainous elevations are linearly moving forward on the inner wall of right atrium. Now those muscles are called pectinate muscles. What are those muscles called? Pectinate muscles. So now I will explain what is the elevation inside the cavity, crista terminalis. Behind it, what is it? Sinus venerum, smooth part. In front, there is pectinate part, trabeculated part. Due to pectinated muscle, pectinated muscles are making ridges. This is muscular part of the atrium, and very important thing, that this is present interior. So when you are inside with endoscope, you are looking. If you want to identify approximately where is you want to mark the nodal region. If you find trabeculated part, you have to come back and find a vertical ridge, crista terminalis. And if you are looking on the posterior wall, which is looking smooth, you move outward until you find again what? Crista terminalis. Deep inside it, not deep to it, you will find nodal region. Is it clear? Now, if I say, where is node? A simple doctor will say it is in the right atrium. It's better to say that it is in the right atrium in its upper part, upper outer and posterior part. More technically speaking, if you are a very good doctor, you will tell the landmark. What are those landmarks? You will say that it is not just a node. It is not it is three-dimensional structure, not a circle, or it is not an oval, right? It is three-dimensional structure which is buried in the outer wall of the upper part of the right atrium. It is just below the superior Cavo-atrial junction, just under the Sulcus terminalis, right? Or you move from this to outward, you will where you will move? Very thin layer of atrial myocardium, 1 millimeter or even less, then sulcus terminalis, then fat pad. This longitudinal sulcus terminalis and fat pad, it should be respected. You know why it should be respected? Because our beautiful this is looking into that side. Why it is looking there? There is something special there. You know, this doll is ladylike. She is expecting something from that side. What it is expecting? Nodal artery is coming here to supply it. Blood supply is coming. Even autonomic plexus and sympathetic and parasympathetic supply is coming from here. From where? This sympathetic and parasympathetic supply to the nodal region and arterial supply to nodal region, this is coming deep to the epicardium, within the fat pad, just outside the sulcus. And from the sulcus terminalis, arterial branches will penetrate the nodal regions, and autonomic fibers will also penetrate, even lymphatics will penetrate, right? So that sulcus should be respected. Now, this junction, you will, I think many times I revised it, but I want to make one more beautiful point about junction. Actually, this junction, which is superior cavo-atrial junction, around this junction, nodal artery appears. I will tell you from where it is coming, but it appears. Definitely it appears here. And then it goes into sulcus pad, right? Here the vagal nerve, right vagal nerve appears. Here also sympathetic cardiac nerves appear, and all of them go into that pad. This is very important, that when you are doing some interventions here, not only you respect, you don't damage the true acinodal tissue, you have to protect its arterial supply and neural supply, autonomic supply. So we can say that if this is the, what about this? Superior vena cava and atrial junction. At this junction, blood supply is coming and neuronal supply is coming. Even though, like most women, this lady also likes to be independent, but loves to be modulated by external influences like sympathetic and parasympathetic. And she is looking very eagerly from where she will get the resources and from where she will be controlled. Autonomic control is also coming from the epicardial side and subepicardial side, and artery is also coming from epicardial side. Very briefly, actually the origin of acinodal artery is variable. 60 to 70% acinodal artery is derived from right coronary artery. 60 to 70% cases, acinodal artery is derived from right coronary artery. And about 30 to 40% of the cases, acinodal artery is derived from left circumflex artery. But once this artery reach here, it can do different tricks in different people to reach its neurovascular corridor. Artery might encircle superior vena cava from the front or from the back, or sometimes it comes here, divide into two and encircles both branches and then come laterally and then enter into sulcus and fat pad. Here also there is one clinical point. If right coronary artery has some severe obstruction, for example, there is rupture of plaque, atheromatous plaque, if right coronary artery, it supplies the inferior part of left ventricle and some portion of right ventricle also. But actually, if there is very severe blockage of right coronary artery, it might result into inferior myocardial infarction. And in patient with inferior myocardial infarction, as we are expecting that right coronary artery is blocked, then if block is proximal to the origin of acinodal artery, then acinodal blood supply is also reduced. Acinode becomes ischemic, and that may produce bradycardias, slow heart rate. Now, you know, in most of the myocardial infarctions, there are tachycardias, right? Because of sympathetic overflow, most of the MIs. But in inferior MI, you might come across a patient who is having bradycardia, slow heart rate. Why? There are two big reasons. One reason is that inferior MI occurs due to blockage of or in severe insufficiency coming from right coronary artery, and in 60 to 70% cases, this artery also supplies acinode. So, inferior MI will occur and acinode will be also ischemic. So, when acinode is not working well, it may not be producing automaticity and heart rate may go down. And if you meet some super good doctor, he will tell you one more reason. But the doctor should be super good. He will tell, not only there are chances acinode is damaged and producing bradycardia, in inferior MI, another cause of bradycardia is increased tone of vagus, right vagus. right vagal tone is increased. Why? Because usually we say that when there is myocardial infarction, there is severe pain, cardiac output might drop, and both conditions can activate sympathetic nervous system. But what I am saying that in inferior MI, you might come across a patient who has bradycardia. One reason for bradycardia is that SA node may be ischemic. Second reason for bradycardia is that there is significant increase in vagal tone coming to SA node, and that is producing what? Bradycardia. Why? Actually, inferior wall of left atrium, left ventricle, sorry, inferior MI is inferior wall of left ventricle, and surrounding myocardial tissue has special sensors which are connected with C fibers of vagus as afferents, as sensory fibers. So vagus nerve has sensory fibers going to the inferior part of the left ventricular wall, and there are sensors, and these are slow conducting fibers, sensory fibers. So when these C fibers and their receptors or sensors are damaged due to ischemia or damaged due to reperfusion, they give very severe sensory input to the vagal nuclei, and severe vagal output comes, and that also contributes, vagal motor fibers, that also contributes to bradycardia. How vagus nerve can produce bradycardia and heart block, we'll discuss in detail later, right? So we have improved our concept in the outside. Previously, now if this our beautiful doll is looking outside, things are little more expanded in concept. First, 1 millimeter thick, rather 1 millimeter thin atrial myocardium. Then there is sulcus. Then in the sulcus there is fat. Then in the fat there is avinodal artery, and with that, acinodal artery. Then with that there is what? Autonomic fibers and lymphatics in that fat. So this is looking there, probably expecting all these good things, right? Nutrition and its controllers, sympathetic and parasympathetic controllers. And more outside the sulcus, then you find epicardium. Is that right? And then outer part of pericardium, and then phrenic nerve. Yes. Now I want to say a few more words. Up to now you are absolutely clear that it is in between the upper part of, what is this? Sulcus, and what is this? Crista terminalis. These are, number one, anatomical landmark between the smooth part of atrium, one external landmark, the sulcus terminalis, one internal landmark, Crista terminalis. These landmarks are basically anatomical landmark or watershed area, which is telling that posterior to it there is sinus venerum, smooth part, and anterior to it there is trabeculated atrial part or rough part of atrium, or pectineus muscle, loaded atrium or atrial appendage, right? Number two, sulcus terminalis outside, and what is this? Crista terminalis inside. They are also embryological junction, where two different embryological developmental areas fuse with each other. Posteriorly, a smooth part which was derived from right part of sinus venosus, and anteriorly trabeculated part which was basically derived from primitive atrium, right? Now, this is just we have done that where is precise and exact location of sinoatrial node, right? And this should not be called exactly node. More appropriately, in modern cardiology, I think it should be called sinoatrial region. Now, sinoatrial region, again I'm repeating it, is very important to identify, but it cannot be identified by the naked eye because this tissue, modified myocardial tissue, which has developed a lot of capacity for automaticity and lost the capacity for contraction, this tissue very gradually merges with the normal atrial myocardium. As it cannot be visually inspected and demarcated, so we reach approximate location of this by anatomical landmark. My good student should remember at least 3 landmarks. What is this? Superior Cavo-atrial junction in the right atrium in posterior, lateral and superior corner. There is the head. This is elongated area. Externally, it is sub-epicardially and just under the sulcus terminalis. If you look from inside, its landmark or signpost towards the SA node is Crista terminalis, but this is not inside the Crista terminalis. Crista terminalis is muscular mountain range inside, vertical, and it gives pectinate muscle which is moving forward and going to trabeculated part of atrium. Here we will stop today. But why I taught it in such a big detail? Because these days we are doing so many procedures. We are doing atriectomy, or rather atriotomy, opening the atrium, or for some procedure, or we are doing catheter ablation around this area, or we are going to put, you can say, some other intervention here, right? So we should not damage, now I will make it more clear, we should not damage the pacemaker cells in this. Tomorrow, in next lecture, I will tell you that histology of it, that there are pacemaker cells and there are transitional cells and then there are connective tissue network made of fibroelastic tissue with lymphatics and vascular capillaries, of course, and autonomic fibers, and how this network functions. We have to talk about which area is pacemaker cells, which area is responsible within this, which area is responsible for intranodal conduction, which area is specially designed for exit of the impulse. Because previously we used to say synodal area just produces action potentials. Now we go beyond it. It produces action potentials, and in a very specific way it helps the action potential to exit to special preferential pathway. It should exit the synodal region to regular atrial tissue. We will talk about that later. But before I leave you, one more clinical point. I love this mountain range. What was it? Crista terminalis. Crista terminalis has muscle fibers which are very random, and their conductivity is along the fibers fast, across the fibers slow. Let me explain. If this is, suppose this is Crista, what is it? Terminalis. From here, we have opened the atrium. What is this going? Trabeculated part. Now, conduction along this and along the longitudinal bundles of muscles is fast, but across is slow. For example, if muscle fibers are going in this direction, right? If conduction has to go in this direction to this direction, it will be faster. But if electrical conduction has to go across this bundle of muscles, then it will be slow. This property that if electrical impulses trying to cross the muscular bundle from different angles, its conduction velocity changes. This is called an isotropy. So, crista, terminalis and trabeculated area display the property of anisotropy, that is differential conduction velocity of electrical impulses or waves of depolarization. Their velocity is different in different directions. It is more along the preferential pathways of muscles and less across. We will discuss this in detail next time. But I was going to tell you some important things about crista terminalis, because these muscles, this muscular tissue, with aging, it may become disrupted. With ischemia, it may become disrupted. Or by some drugs, its electrical properties may change. So, in many of the atrial tachyarrhythmia, origin is found in crista terminalis or trabeculated part of right atrium. So, crista terminalis might have a arrhythmogenic focus. Secondly, because it is long and with multiple directions. In some directions, current may block, and some directions current may flow fast. And this may lead, as I will explain later, re-entry circuits and atrial tachyarrhythmias. Actually, focal atrial tachyarrhythmias and re-entrant atrial tachyarrhythmia, many a times they take origin from crista terminalis or some nearby trabeculated area. Why it is so important to know? Because these days, by electrophysiological studies, we'll find that focus and we will manage it there by interventional cardiologist, or by catheter ablation, or there are different procedures. But what you remember at your level, that crista terminalis and its associated interior trabeculated area, this has many arrhythmogenic foci, which may result in focal atrial tachyarrhythmias or atrial flutter, right? Then one more clinical thing. This mountain range, sometime one of the mountains, one mass might become very big. But mass may be made of normal myocardial tissue, but it become very big. So in imaging studies, it may be looking like a pseudo-mass or pseudo-tumor, or it may look like vegetation, or it may look like a thrombus. So this is another importance of crista terminalis and trabeculated area, especially crista terminalis, that sometimes they develop a mass which is made of regular tissue, which is not dangerous at all. That is physiological mass, we can say, but it is very important for differential diagnosis because it might look like a tumor or like a thrombus or like a vegetation, so we have to rule it out.
Sir, how do
you differentiate this mass as normal or abnormal? One of the ways that when you do imaging studies, then echogenicity or density, right, of the mass is the same as normal atrial muscle, then it should be considered normal, elevated area. But if echogenicity on imaging or density is significantly different, then you have to do more investigation. Thank you very much.